Please do monitor the chat. I'm going to move along in the interest of time. I want to introduce next Dr. Uma Vadlakunda to share her experiences with us. She is the regional clinical lead for cardiac rehab at Kaiser. She is the co-founder of the Heart Health for South Asians, a health education-based comprehensive program at Kaiser in Santa Clara. And I'm very interested in hearing her experience of the benefits and challenges of delivering cardiac rehab in a large integrated health system. So take it away, Uma.
Thank you so much, Abba, for this wonderful symposium that you've put together. I'm trying to share my screen, and let me see if I can share my slides. And are you able to see my slides?
Not yet, but if there's difficulty, I think we have a backup on our end. Just let us know. We're happy to control them for you.
Okay. I think my slides should be apparent, so let me just verify this. Are you able to see me now or see the screen?
Not yet, no.
Okay.
Actually, hold on. Now I'm seeing your computer screen. There we go.
Okay, very good. Well, like I said, this has been a phenomenal morning hearing all of the talks, and I must say that it was wonderful to see the history of cardiac rehabilitation as it flew through the day, and made me feel very proud that we're all part of this community. I hope you're able to hear me and see the slides. My topic today is delivering cardiac rehabilitation in a large integrated care healthcare system, Kaiser Permanente, particularly Kaiser Permanente, Northern California. And I'm interested to bring to this group today the elements of patient-centered goal setting with respect to cardiac rehab. I also would like to talk a little bit about online PT as it pertains to cardiac rehabilitation. I am going to briefly talk about the CAD statistics that you have heard all morning, and really bring in role for cardiac rehabilitation. Where does that fit in the secondary prevention? And for something that seems to be so important, where's the utilization nationally? Where are we? I would like to talk about cardiac rehabilitation at Kaiser Permanente, Northern California, what we do and what we have done over the past couple of decades. And I want to share a few enhancements, particularly to talk about online physical therapy. In the interest of time, I do plan to give a couple minutes for questions. We'll see. So again, it may be preaching to the choir, but the burden cannot be stated enough. That heart disease is the leading cause of death for both men, women, and people of various ethnic groups racially in the United States. In fact, this is the CDC statistics from February of this year, stating that one person dies every 36 seconds in the United States. So cardiovascular disease burden is pretty significant, and 1 in every 4 deaths is from cardiac disease. Okay, in terms of cost and economic burden, we know that it is a pretty expensive affair as well. And this is data from 2016 to 2017. Heart disease costs in the United States about $363 billion every year. And that really includes cost of the healthcare services, cost of medications, lost productivity due to death, and so on. Well, what's the story at KP Northern California? I'd like to, of course, take that moment to say that we have a slightly different statistic to share for Kaiser Permanente in Northern California. Our mortality rates have steadily declined over the decades, and substantially. This was a wonderful article put together by Dr. Sidney and Dr. Jaffe's group, published in 2011 in Circulation, about closing the gap with respect to cardiovascular mortality and cancer. Okay, this is data of those individuals over 30 years of age that and mortality statistics for cardiovascular disease, stroke, all-cause mortality and death. And you can see that the cardiovascular disease mortality reduction definitely surpassed that of cancer. There was a 30% reduction in mortality from cardiovascular diseases and 42% reduction in mortality from stroke. This is data from 2000 to 2008. So very happy to see that the integrated model with aggressive preventive care and risk factor optimization, the numbers have been really favorable. This is yet another trial published by Dr. Sidney and his group in American Journal of Medicine 2018. And again, this was an outcome comparison in the trends of mortality nationally versus KP Northern California. And this was really looking at total mortality, age-specific, sex-specific mortality for stroke, for heart disease, and all-cause mortality. Looked nationally versus Kaiser Permanente, the numbers were very impressive. And this was a group 2000 to 2015 on members that suffered these events. And the decline was very steep at Kaiser Permanente in those individuals 45 to 64 years of age, the prime age where secondary prevention, primary prevention, all these should be targeted. So we're very happy with the numbers that we've seen. Now, coming back to our topic today. What's cardiac rehab? You've heard this all day, the breadth of topics on what was pertinent about cardiac rehabilitation. I don't have to reiterate, but I just, again, want to bring the definition because I do not want the world to really see this as an exercise program. Cardiac rehabilitation as defined, this was from the scientific statement from AHA and American Association of Cardiovascular and Pulmonary Rehab, stating that it is a comprehensive secondary prevention program. Really is comprising of exercise as well as education and behavior modification, really to designed to improve physical and emotional condition of the patient. So this is a lot more than just an exercise. The goal setting is really getting down to the patient level, really putting symptom control is an important thing. Improvement in exercise tolerance, and most importantly, quality of life. As we see the spectrum of individuals and their ages and where they are in their capacity, it's truly cardiac rehabilitation that enables the participant to achieve their optimal physical, psychological, and social status in terms of returning them back to their vocational functioning. And I think that's a very important thing that both the referring and those referred and the programs need to understand that this is not just an exercise program. I just wanted to share this lovely cartoon. This was from a central illustration in the article by Sandesara's group in JAC 2015. I think this really states it very nicely. Let me just direct your attention to the pyramid here. That heart disease has so many complexities. It's lifestyle issues, the environmental factors like poor dietary habits, physical inactivity, poor unhealthy life practices like cigarette smoking, that in combination with both the traditional and non-traditional risk factors, and you've heard those as to what they are, that sort of brings this culmination of subclinical disease. Already, as we see these youngsters progress, there's carotid disease, there's coronary calcification, there's vulnerable plaques. And if they really reach that point of plaque rupture, this first event may happen. We hope to do the primordial prevention, which is really preventing these risk practices entirely, or primary prevention, which is treating those risk factors so they don't get the disease. Well, we went beyond that and they actually get that first event. Then what we're really hoping is that the second event does not happen. The secondary prevention is that cornerstone where cardiac rehabilitation comes in place. As I have seen all of the presenters point this out, ladies and gentlemen, I cannot help but reiterate that cardiac rehab isn't exercise alone. There's a small component of this. This really encompasses a whole bunch of things. Assessing the patient, doing the nutritional counseling, and you've seen an extensive topic. It is all kinds of risk factor management with respect to weight management, blood pressure, lipids, diabetes, bringing their habits really to be spiffed up, tobacco cessation, psychosocial assessment, and activity counseling. That's where these are tied into, and we can continue to work with these vulnerable individuals. So really, prescribed exercise, we've seen the Borg scale, we've seen the cardiac rehab programs really bring that little bit of a structure to the patient, saying, well, this is where they've got to be, this is where they are, and what can they do without exceeding safe limits. Absolutely catch them at their vulnerable most and give them the entire spectrum of cardiovascular health. This is their time to quit smoking. They need to understand the plaque ruptures caused by this. Lipid management, blood pressure, weight loss, and diabetes. This is no longer a time to say, I can't tolerate statins, I've got muscle aches. This is the time to hold their hands and say, well, I'm sorry, this is life versus death. And you've got another event coming, and we've got to make this vulnerable group accept. And I think cardiac rehabilitation as a program has this very, very powerful purpose of taking those patients through the journey, healthy eating and psychological well-being. Well, why can't the cardiologist or the primary care physician assign this to the patients and give this key message to the patients? Why do we really need cardiac rehab? Well, we need cardiac rehab because it is a multidisciplinary, systematic approach. It is something that's proven, and it is proven to improve outcomes. And this is really a secondary prevention systematic program. It has shown in meta-analyses of 35 to 40 trials, and if you've seen several speakers point these, that it reduces recurrent MI, it reduces mortality. Okay, and there was a community-based study looking at absolute risk reduction in those individuals who underwent CABG and participated in cardiac rehab programs, that there was a 12% absolute risk reduction. It reduces hospital readmissions, and it absolutely improves quality of life. So why not the cardiologist? Why not the primary care physician? It is because this is such a targeted program, really trying to make a difference for these individuals. Well, that's a fact that almost seems very well known. The group you're listening to it feel like, oh yeah, we know this. Well, then it should be so heavily utilized, right? So what's rehabilitation across the nation? How well utilized is it? This is one of the many trials you've heard through the day, is really cardiac rehabilitation participation and completion rates among the Medicare beneficiaries. This is published in 2020. And group individuals who've suffered cardiac events who qualify for cardiac rehabilitation, and how many have been referred. And it was very interesting to see that in those eligible, less than 25% participated, less than 25% were enrolled in this program. And of those enrollees, less than 25% actually participated or were sent to it less than a month into their event. So that really took out about 7 million missed opportunities to really make a difference in secondary prevention for this group. So I think something that should be well known isn't well utilized. There has to be a reason for that. And again, this was a wonderful review article that was put in and published in JACC. And I think that I've provided the reference. And really, it went through the nuts and bolts of trying to get to the root cause of why would that be? You've heard this all morning, that the traditional in-person cardiac rehabilitation programs that actually were in existence had some inflexibilities to them. There was a question of such people, the vulnerable individuals of certain ethnic groups, lower socioeconomic strata, and women particularly were not adequately referred to these programs. I think it's also seemed to be an issue of lack of a centralized referral system. There were reasons looked into see, well, perhaps the physicians and the providers that do the referral for these programs are not adequately informed. And I think education definitely is in order. It's not that it's as a physician that deals with cardiac patients, it's very disheartening to hear this, but I think they may just not be familiar with the benefits that a cardiac rehabilitation would afford on the top of the standard care. They know about doing DAPT therapy after a stent, but do they know about doing the cardiac rehabilitation and the mortality benefit? Okay, so it seems to be that there's logistical problems to an in-person on-site visits where we've heard our surgeons say that it's difficult to get a ride to go to these programs. There's not that many programs available. And so there's a not only a referral inadequacy, there's availability and demand problems as well. Cost is a big problem. Not every insurance has been adequately compensating for this. So I think with all of these issues, along with frailty, along with the referral concerns, I think there was a big push towards saying, well, I think we've got to reinvigorate this. We've got to rebrand cardiac rehabilitation program. It has to really be patient-centered. You cannot have this guy who sits on a wheelchair to be able to run on in person at cardiac rehabilitation facility and be able to run with it. Really meeting the patient where they are, applying appropriate comprehensive goals for these individuals and making it accessible for these patients. Have the models be a little bit varied. What do we mean by that? Really, I think, again, the Clinical Performance and Quality Measures Task Force by ACCHA that was published in 2018 has absolutely endorsed not only the traditional supervised exercise, but really to go for alternate models. We've got to find ways to reach out to that vulnerable patient who's had the event and say, well, how can I provide rehab to that individual? Not the selected out, the one person who can come into the center. Okay, so home-based cardiac rehab model, remote monitoring and mobile health strategies were definitely talked of as possibly the solutions for these individuals. Okay, so really the idea is to improve our referral participation and get these individuals to take benefit of the secondary prevention programs. So again, as an individual that is going to be talking about cardiac rehab at Kaiser Permanente in Northern California, not trying to bias individuals one to another, but this is truly one of the things we got to look at for why the referral is so low. Traditional programs are difficult to access. It is costly. There are issues with systems, issues with providers. Now, remote rehab programs, as they're emerging, and as they're improvising, they're patient-centered. They're a lot more accessible and a lot more affordable for individuals. Now, we will come to Kaiser Permanente, Northern California's cardiac rehab program. As we talked over the decades of programs and how the in-person versus the remote programs need to come into existence, I can tell you that Kaiser Permanente Northern California has had a robust home-based cardiac rehabilitation program for the past 2.5 decades and more. So we haven't invented this yesterday. We have seen a meaningful, comprehensive secondary prevention happening now for the past couple decades. It is a program comprised of care teams, including a cardiologist program director. This is all according to the CMS guidelines, very well established, and the RN and PharmD care managers that provide the care along with program assistants. Now, we have about 19 medical centers in Northern California. Each of them have their wonderful autonomous program with their program director, care managers, and program assistants with their referral bays. Yet we all work under the umbrella of one region as a family. Now, again, this is groups that the care managers get the referral. I'm going to show you the follow-up is for 6 months, and the follow-up can be weekly to about monthly based on the need and based on how well the individual is progressing. And the cadence of contacts is very personalized. They're virtual, although some sites definitely offer in-person visits and sometimes treadmill testing. When an individual is referred post-event, and we absolutely try and do this pre-discharge through very strong education to the interventional group, the hospitalist group, and general cardiology, that we want to catch these group before discharge in terms of if a physician or a provider tells this program to the individual, they are a lot more sold on this program. So the referral happens, and then a personalized care plan is developed by the cardiologist along with the care managers. And they really go after medication adherence, blood pressure control, and lifestyle modification. And now I'm going to tell you all a little bit about the online physical therapy. And after their 6 months of follow-up, they're handed off to a warm hand off to the primary care teams. In fact, we do have a program called PHASE, preventing heart attack and strokes every day. And that's a group that actively follows these individuals after the 6 months. Does it work? How effective is our program? Well, this is the enrollment, ladies and gentlemen, nationwide. Less than 30% are enrolled in cardiac rehabilitation. This is KP Northern California. This is data from February or March this year. More than 75% of patients are enrolled in cardiac rehab in a very timely fashion. Our post-MI beta blocker adherence on the HEDIS measure is 94 to 95%. Our smoking cessation rates are 98% and above, which is phenomenal. So these are individuals who have comprehensive secondary prevention. Does it work? We're still on the process of does it work, right? I'm going to briefly share, I know in the interest of time, I'm going to, Dr. Levin, who'll follow this talk, will also share some Kaiser data, I'm sure, but I'm going to be telling you about this one trial about the cumulative adherence of secondary prevention guidelines and mortality after an acute myocardial infarction. And this is Dr. Solomon, Dr. Rana, Dr. Levin, and the group have used this, published it in Journal of American Heart Association in 2020, really looking at individuals post-event following goal-directed medical therapy, both medication, clinical parameters, as well as lifestyle changes, whether it be medication adherence, whether it is smoking cessation, and so on. 6 to 7 of the goal-directed medical therapy parameters were looked at. And what was seen as and they were followed for 30 days and 90 days, those that were post-MI undergoing these goal-directed therapies. And those individuals who have followed the 6 to 7 parameters really had a significant mortality reduction. And what was interesting to see is each additional guideline recommendation achieved after 30 days and after 90 days had a further reduction in mortality for this group. This was a Cox proportional hazard model that was followed, and it was a 0.57. It was really significant outcome benefiting intervention. Why did I share this article? It is because all of the 7 parameters were followed by cardiac rehab group until the 6 months. So it was truly a life-saving intervention, and our program works very well as a home-based finding. So the findings of this trial and the conclusions was cumulative adherence to guideline recommended medical therapies and risk factor control and lifestyle modification after discharge were associated with significantly lower long-term mortality. The incremental favorable associations were observed with long-term survival, with each additional guideline metric, even at a high level of adherence, gave even further mortality benefit. So does it work? Absolutely, it works. Now coming to HEDIS measure and the enhancements we've done, I think I have just a couple more minutes left. Of course, the new HEDIS measure has really brought in the parameters of initiation, engagement, and achievement. And this is for qualifying individuals who are 18 years or older who attended cardiac rehab after a qualified event. And this really needed to be the 2 or more sessions for initiation, 12 or more for engagement, and those that finished the 36 or more events within the 180 days. And that's really what they're hoping in the Million Hearts Initiative, is hoping for 70%. Now, home-based cardiac rehab models have to look at, and programs such as ours that provides very comprehensive help as to look into see where we fit into some of these, because we definitely have the initiation, engagement, and completion rates. So one thing we have done as an enhancement is put forth a bit more structure and a structured explanation for exercises for these individuals, and brought in this platform, which is a wonderful integrated platform for exercise for these individuals. It is really platform to increase the access and usability of physical therapy to individuals. So when a clinician refers the individuals to our cardiac rehab program, and the care manager assesses their ability to exercise by a questionnaire, and then they're assigned these programs. It's a tool for the clinician to assign the programs and engage with the patients, monitor where they are in their exercises, and all these through our electronic medical record. So it's very well married to our medical record, and it provides a very good tool for exercise instruction. And it's a tool for the patients to see where they are, what they've been assigned. And these are lovely videos that are very much geared toward patients. The cardiac rehab program through this platform was actually created by us by bringing in the appropriate stakeholders with a few cardiologists, physical therapists, and cardiac rehab managers. And we put forth exercises geared towards individuals of all spectra, those that are wheelchair bound versus the young guy who needed the hip training. And so based on where they are, this program can actually assign. So the care manager follows the patient throughout the course, and then once they have assigned the exercises, the manager checks the periodically, whether it is a weekly or twice a weekly on their electronic record. They help connect and see if they're actually doing those exercises. It gives them an opportunity to send off a communication saying, hey, Joe, by the way, what happened in the past 2 days? You happened. So I think that kind of an ongoing motivation is provided. And the care manager is nicely able to advance exercises in collaboration with the patient. This is truly meeting the patient where he or she is. And so that an individual who walks with a walker is nicely given their exercises to their level and taking them to the next step, follow the goals that they have and they're interested in using. And so once the assessment is made, the care manager actually gives those repetitions of exercises on sitting and standing and heel raise and stuff like that, based on whether they're aerobic very good or aerobic not, whether they're limited or whether they're not. And these exercises are assigned to the patient, and they are followed as the provider is able to see it, the primary cardiologist is able to see it, and the care manager is able to see it. The patient can actually communicate with the clinician and say that they have been having a little bit of a shortness of breath or limitation in exercise of a particular thing, and they can be downgraded or upgraded based on where they do. So this was one enhancement we put forth, and it is well received by our members, and our care managers are trying to make this more comprehensive program. So I know in the interest of the few minutes, I just wanted to summarize that Kaiser Permanente Northern California has very successfully followed home-based cardiac rehabilitation program, which is totally patient-centered. We have a track record for the past couple decades, and it is a comprehensive education and risk factor optimization. And we're hoping that this message of trying to enhance constantly to where the patient is and how we can put the goal setting and make them continue to not only be participants in this, but to successfully complete the program. Well, that's who we are at Kaiser Permanente. I would like to thank Stanford for giving me this opportunity to share who we are. I'll be open to questions.
Uma, what an excellent job. Thank you so much. And again, in the interest of time, there are some questions in the chat, but I'm going to move on and ask Dr. Levin to unmute herself. And I am delighted to introduce her because she is a full professor in the Department of Medicine. And prior to coming to Stanford, she completed a long tenure at Kaiser Permanente. She was the regional expert in lipidology there. She served as a chief of cardiology at Santa Clara for 16 years and chair of the chiefs of cardiology, which I think includes over 120 cardiologists for Northern California for over 8 years. She directed the regional cardiac rehab program using home-based comprehensive rehabilitation across 18 medical centers for nearly 3 decades. During this time, she has led teams developing cardiac guidelines, embedded order sets, and electronic medical records through Kaiser to help improve quality. And she's spoken about and presented her work on population management and quality improvement nationally and internationally. We were very lucky to have her join us in 2018. Currently, she teaches medical students, medical residents, and has a busy part-time cardiology practice. She also is directing the Stanford undergraduate shadowing program and conducts collaborative research in cardio-obstetrics, value-based care, and cardiac rehab. Her experience and knowledge is vast, so I don't want to take away any more time from her. So with that, I'll let Dr. Levin start her presentation.
Okay, I should be up. I'm going to share my screen and share. Here we go. And we'll go to speaker mode. That works, slideshow. There you go. Okay, so we're going to go fast because I have 5 different programs to tell you about. My disclosure, I'm in my part-time work. I'm also Chief of Medical Affairs at Moving Analytics, which is a home-based cardiac rehab app, virtual, with a care management program. So we're going to skip through quickly value of cardiac rehab and underutilization because everyone has talked about it all day and we know all about it. And I'm going to go pretty directly to examples and outcomes of virtual home-based cardiac rehab programs. And questions and discussions will have to be in the chat so that we can proceed on to Alex Perino's talk on remote monitoring. So we all know this, 1 in 4 people have already had a heart attack. Of those who then have a heart attack again, and cardiac rehab can help you recover and also prevent further problems. Women, minorities are less likely to get care. Older adults, because of these problems with transportation, also get limited care. And we know this is going to help us. And we can read the slides here. And I'm going to skip through this, but it basically, as Uma said, very few people compared to what could be done are getting cardiac rehab across the country. And if we filled all of our existing centers at maximum capacity, we would still only get 47% of qualifying patients in the US. So we need to have alternatives. I'm going to go through some successful home-based cardiac rehab programs, including digital solutions. We're going to go quickly through KP Northern California because Uma Vadlakanda gave a wonderful review. And then I'll touch on these other 5 programs: Kaiser Permanente Northwest, UC San Francisco, Johns Hopkins, Emory based at the VA, and Highmark Health, which is a Blue Cross Blue Shield program. And this particular case study was done in the city of Pittsburgh. This was a poster that we presented at the American College of Cardiology in 2017, which can show you in detail the care manager outreach workflow from Kaiser Permanente, including the high-level workflow and the summary of the excellent results, which Uma already gave you. So you can look through these slides. I'm just going to make them so you'll be able to read them when you get the slides, but it gives you the nuts and bolts of how the program works. And in summary, with from 2013 to 2016, beta blocker adherence was 92 to 96%. Smoking cessation by the end of the program, 97 to 98%. blood pressure control, 85%, LDL control, 83%, 47% were exercising greater than 150 minutes a week, and 84% were low fat diet. We were trying to push a vegan diet. Only 17% of the patients could really achieve a plant-based diet. So I often tell my patients, hey, vegan every other day, and that they can do. The next program I'm going to discuss is Dr. Gray's program of virtual cardiac rehab in Kaiser Permanente Northwest. They have similar outcomes, and what they found is that when they used only center-based programs, they got very minimal enrollment compared to when they switched completely to a virtual cardiac rehab program. So their completion rate for virtually enrolled patients has varied between 79 to 84%. They use the moving analytics program. Prior to going virtual, they had 25% enrolled. After using virtual, 85%. Their graduation rate changed from 14% to 88%. They had 4.5 engagements per member on the virtual program. They've enrolled over 1,500 patients, and they were up to 123 weekly exercise minutes. This was presented at the ACC conference for CV Transforum in 2020. The next program is from Alexis Beatty's program. She's an associate professor at UC San Francisco. She compared, and this you'll be able to see detailed when you get the slides, but she compared a virtual program, a hybrid program, and center-based program. And this tells you how she set up the study. And what she found is there was no statistically significant difference between either in-person, hybrid, or completely virtual program in terms of improvements in exercise. So they have a wonderful virtual program at UCSF. The next program I'm going to talk about is the Corey Health Virtual Cardiac Rehab Program. And this is led by Seth Martin. He's an associate professor at Johns Hopkins University. And this is a total solution, includes a Corey kit with a smartwatch, blood pressure cuff. It's a smartphone app, and they have a dashboard. They did a study that they've published in Digital Health Intervention in Acute MI in 2021, and Cost Effectiveness, another article in Medical Care in 2021. And what they found using a digital program post-MI is they had a 52% lower risk of all-cause unplanned 30-day readmissions. And in their case, they had a cost savings of $72.74 compared with standard of care. And this kind of gives you an idea of the 12-week virtual program, similar to the 6-month program that is used at Kaiser Permanente in general. The next program I'm going over is Arash Harzan's program at Emory Healthcare at the VA. He's an assistant professor at Emory, and this is his contact information if you want to learn more about his program. Arash concentrated on a very special population, the veterans, and the veterans have a less than 10% participation in cardiac rehab in a traditional centered program. So this was a completely virtual cardiac rehab program. They scheduled weekly visits via their VA Video Connect. They had a dedicated coach, either a PA, NP, or an exercise physiologist. They had a comprehensive program, including health psychology, nutrition, and whole health. They also used this Move-In smartphone app. They provided a Fitbit or Garmin and had scheduled phone sessions, also had a dashboard, but individualized programming for this special population of veterans. Again, we see how you can have a two-way data flow on a virtual platform. And this is just the Cochrane reviews, which was already said earlier in the day about how home-based cardiac rehab is similarly effective as center-based and can support continued expansion so that you're able to reach more patients if you have a parallel program with your center-based program. In other words, you can keep your center-based program for those 20 to 28% of people who will come, but then add on a second virtual program to capture another 60% of patients who would benefit. Veterans were receptive to virtual. They had participation, which was 6% at many of their sites, and it went up 4 times to almost 25%. This is data specifically from his Atlanta VA pilot project in 2016 to 2020. And this shows the event rates between center-based, home-based, and their virtual-based. And the one-year event rates were just as low as the center-based, maybe not statistically different, but very, very low. They also increased the exercise capacity with virtual cardiac rehab. And they had an improvement across all the risk factors, including smoking, and hemoglobin A1C, total cholesterol, LDL cholesterol, also PHQ-9 score and depression. I'm going to move on now to a private sector health plan, one of the largest Blue Cross Blue Shield insurers. And they used a pilot program called Vital. And this was the leader, Ben Echazu. And he previously was the lead in their innovation department, Blue Cross Blue Shield. He's now a vice president of strategic alliances at Moving Analytics. And this is his contact information if you have any questions about his program. Again, very similarly, there's a dashboard, you get a iPhone, a watch, the blood pressure cuff. Again, it's a 12-week virtual program. They're all very similar in terms of their programming. And this shows you how you can have a care manager and also a little bit of reinforcement in terms of phase 2. Note that in months 4 through 6. I'm going to leave this on for a second so you'll see it in the slides when they get sent to you. And this was their prospective test study design. And I'm not going to go over the costs, the all-cause readmission, all that in the interest of time. I'm just going to show you the participation metrics because they were able to get much more participation by having these parallel programs. Patients were able to choose, do they want to come to the center? Do they want to have virtual? So with those choices, you got a lot more patients enrolled, therefore a lot more patients got treated. And here they're showing the difference between centers and using a remote program. Completion rates. Completions for the moving remote cardiac rehab program were greater than for members attending the center, and 76% of all the virtual patients had a graduated status versus only 45% of those at centers. So in conclusion for their study, having a remote program, in this case using Moving Analytics, resulted in higher overall participation in cardiac rehab compared to participation described before with only centers. More completed the full program than in traditional rehab, and a smaller percentage had hospital readmission, but this was not statistically significant. So there are the similar benefits from a virtual program as compared to a center-based. So this is an opportunity for us to expand the treatment to a whole cohort of people who would only do a virtual program. So we already went through that. And as I told Abba, I speak very fast. So we might have almost gotten ourselves back on track with time.
That is true, Dr. Levin. I didn't expect such a fast overview. That's amazing. I will move on to Dr. Perino, who's last but definitely not least. And there are some questions in the chat, Eleanor, if you wouldn't mind taking a look at those. And so Dr. Perino is an assistant professor of medicine and an electrophysiologist at Stanford. He also serves as the director for medical informatics for CV medicine. And as a researcher, Dr. Perino uses large data sets to examine quality of care, outcomes, and risk prediction for heart rhythm disorders and cardiovascular disease. His research is currently funded by the American Heart Association and investigator-initiated awards. I know that arrhythmia is a growing concern in an aging population who are utilizing cardiac rehab. And I think with the new wearable technologies, I think you will have lots of questions. So I will let you get started, Alex.
Thanks, Alba, for that very kind introduction and for the opportunity to talk with our 410 participants who stayed past 3 o'clock. So thank you, everybody. Just give me 1 second here to pull up my slides. Are you guys seeing the presenter view or the slideshow view?
The presenter view. Oh, sorry.
Better.
I'm seeing the slide. I reverse it, Alex.
No
You were
worries.
correct before.
All right, so these are the correct slides. View.
Yes.
Great. Well, thanks everyone for sticking around to hear my talk. A lot of what I'm going to cover dovetails into what Eleanor talked about. And, also considering in my experience that attendance decays exponentially after the expected end time of a conference, I'm also going to move rather rapidly. A few quick disclosures. I'm a consultant for a few companies, but none of these companies' products are discussed in this lecture. And I think also probably more importantly, I have an intellectual probably disclosure that I'm a clinical cardiac electrophysiologist. And so a lot of my viewpoints and perspectives are heavily shaped by that clinical experience. And at times I may have an overly arrhythmia, centric view. So a few objectives, a few topics that we'll cover is just a case presentation on a cardiac rehab arrhythmia scenario that I dealt with recently. And then also a brief review of some digital heart rhythm devices. And I think that'll be really useful in conjunction with what Eleanor talked about and showing how those devices are being used in cardiac rehab, and just kind of explore in more detail, what those devices have to offer and what are, theoretically use cases for them. And then I think, very importantly, when talking about these device types is, how are we integrating the data from these devices, into our existing clinical workflows and electronic health record systems. And so I'll share some work that we've done here at Stanford on that topic. So diving into the case presentation, this is a patient that I've been caring for a little over a year, a 58-year-old man with hypertrophic cardiomyopathy. I have his echocardiogram here where you can see his thickened septum. And he underwent a myectomy to improve the outflow tract gradient that these patients commonly have that can result in a lot of symptoms. And the surgery went very well. He developed a left bundle branch block after the surgery, which is not uncommon. And as a result of just surgical removal of that septum and injury to the bundle. And he was appropriately referred to cardiac rehab. And he was one of these patients who is a very diligent participant in cardiac rehab, going to, sessions and engaging very, vigorously. And on a Friday at 4:45 p.m., as I was just about to shut my computer down and unplug for the weekend, I received an email that he'd had some bradycardia when he was at rehab. And so I opened the email and I noticed that it's been forwarded to 4 different people through Stanford, finally reaching me. And it says that he had a heart rate of 40 beats per minute and had some lightheadedness while he was at rehab. And I open up this attachment, which I really have to emphasize couldn't have come a minute before. I wouldn't have seen it potentially for days. And there's some rhythm strips. And in the first rhythm strip, you know, when you glance at it and you see some QRSs going and they're at a reasonable heart rate and you're not too scared, but when you look a little bit closer, it looks like there's P waves and a much greater number than the QRSs, suggesting he's in some type of heart block, likely high grade. And then the next strip on the attachment showed complete heart block with numerous P waves without any conducted beats and a few escape beats. And then finally, there was a very ominous wide complex tachycardia, which if you're an optimist, you would think is just return of his conduction with his known left bundle branch block. And if you're a pessimist, you have to wonder whether or not he went into ventricular tachycardia before expiring from his complete heart block to maintain perfusion. So really the most terrifying email I've ever received at 4:45 as I was about to close business. I called him and he picked up the phone, was doing great, came to the hospital, and we implanted a defibrillator to both provide, you know, pacing if these events happen in the future, and also to provide shock should he have any ventricular arrhythmias as a result of his hypertrophic cardiomyopathy. And he returned diligently participating in cardiac rehabilitation. But, you know, it really made me wonder, and in particular with work and with digital heart rhythm devices and electronic health record clinical integration, like it felt like there was a lot of opportunities here that we could have upstream of this event and at the time of the event made different decisions, provided, you know, different care to make this a less scary email for myself and for the patient to receive. And so, you know, kind of switching over to digital heart rhythm devices, there's a practical guide to digital heart rhythm devices that was published in Europace in 2012. I have a QR code here on the screen, so if you scan it with your smartphone, you can go right to the publication. And they have this very nice figure one in which they kind of lay out the different device types that are, you know, currently available. And so starting on the inner ring on the left side, they have, you know, PPG based or photopulse tomography, where actually the pulse ox is used to look at heart rate and heart rhythm. And on the right side of the screen, they have, you know, ECG based. So, you know, like an EKG, just like a 12 lead, but usually less leads and with more mobile device type. On the second ring, they show that some of these are, you know, are handheld versus wearable, denoted by the hand and the shirt. And then on the third, the blue ring, they show the placement where these might be smartphone based, watch based, or, you know, handheld ECGs or patch or kind of band-based ECGs. And on the final ring, they kind of walk through each of these where there's, you know, using a smartphone camera and light, you can look for pulse irregularities to note arrhythmias. That there's face sensors that look similarly for the pulsations of blood flow in the face that these cameras can detect to look for irregular heart rhythms. And then our smartwatch, you know, PPGs like that are contained like an Apple Watch, for example, fitness band PPGs, you know, like a classic Fitbit, and then handheld ECGs with CardioMobile being an example, and a smartwatch ECGs, which are also contained on Apple Watches. And then a patch-based ECG, which is, you know, less of a direct-to-consumer product and is more commonly seen as a prescription from a healthcare provider like a Zio patch. And then these kind of lead-based ECGs, which is a variety of products like a chest strap that performs an ECG. And so diving into these a little bit more into the two types that I'm encountering the most often in clinical practice. So these handheld ECGs. So here's an example of a few products, the top one being a LiveCore CardioMobile. These are often paired with a smartphone or other device. They can provide a single lead or up to a 6-lead ECG. At least for the CardioMobile, which I've seen the most in clinical practice, the tracing quality, I would say, is equivalent to an in-office 12-lead ECG, and it can be obtained very rapidly, much faster than the application of all of the stickers and leads necessary to get a traditional ECG. And they're useful to, you know, check rhythm during symptoms. You know, if patients are feeling lightheaded or otherwise unwell, these can very rapidly determine what the heart rhythm is during these associated symptoms. And they can also be used for either like opportunistic or scheduled screening to look for arrhythmias. However, they only work if you use it. I have one of these to you know, which I use to kind of stay abreast of what my patients are using. And every once in a while, I'm like, oh, I should use this for fun. And I don't have it. I got to go find it. So that's certainly a drawback. I think a big advantage though is that they're relatively inexpensive. They market from anywhere from $80 to $130, which is, it's not nothing, but it's certainly less than other products in the space. And then, for cardiac rehab patients specifically, these are something that perhaps in select cardiac rehab patients, they could use outside of their traditional cardiac rehab to check rhythms. And for our patient that we presented earlier, maybe this wasn't his first episode of, alarming heart rhythms, and maybe these could have been detected with one of these devices well upstream of this event. They could be used in combination with many of the hybrid cardiac rehab programs that Eleanor talked about. And they could also be used in traditional cardiac rehab just for more expeditious rhythm checks. They're much easier and quicker to use than, for instance, 12-lead ECG. And a lot of arrhythmias are very transient. And perhaps by the time a 12-lead ECG is checked, the rhythm has passed. The smartwatch is another very common device that we're seeing people use. And so these can be used for, episodic single ECGs. So you as the user trigger an ECG. But they also have a lot of other features that are relevant for cardiac rehab patients and providers. And that's that they can, provide heart rate measurements and also a regularity of the heart rhythm via PPG. And so, very useful for tracking patients' heart rates during exercise and at rest. I have to say for the ECG feature specifically, the tracing quality is a little bit lower than the handheld ECGs that we showed on the previous slide, but the device portability is much greater. You wear the watch, it's with you all the time, and so that is certainly a plus. And then they have these additional non-heart rate or rhythm related features like pulse oximetry, at least on an Apple Watch. They're relatively expensive though, and so this price point is for many patients, not something that out of pocket they are able to burden or find acceptable for the benefits they provide. And then, specifically for cardiac rehab, a lot of these are paired with a lot of the programs that Eleanor presented, and they provide a lot of dense data collection both inside and outside of rehab to see how your patient's heart rate and rhythms are responding. And they could also, in some instances, replace traditional telemetry in patients at low risk for arrhythmias. There's some real world issues with these devices though, and I think front and foremost is that the clinical integration is lagging. Patients have these, they're collecting data, and we as a community don't know how to receive that data, review that data, and to provide recommendations and care for our patients. So at least in the KardioMobile, you can obtain an ECG and then email it to somebody. But that raises a lot of issues of how do we get this information from our patients? Having them email it to our personal or work email accounts can certainly be problematic, is we may not be reviewing that information or seeing that in real time, and also there's kind of work-life boundaries that are challenged with that, and there's also a lot of medical legal risk as we review these and sometimes give out recommendations without appropriate documentation. There's also a lot of concern, and we're certainly seeing it in the real world of these devices, identifying heart rhythms that may or may not be concerning, or even sometimes identifying artifacts, and patients have no heart rhythm issues. And as a result of this, though, there's a triggering of low yield diagnostic evaluations and a lot of concern for increases in healthcare utilization, resulting in increased costs. They can cause anxiety and stress for patients. And another issue with them is, in healthy patients, but also cardiac rehab patients, we don't really know what the background rate of what you might think of as like less concerning arrhythmias are. Some data on that in a second. And then, of course, there's a lot of issues with widening the digital divide. You tell a patient, hey, it'd be great if you get an Apple Watch. A lot of patients cannot afford that. And if there are, improvements in health outcomes from them receiving that watch, then that's certainly going to be problematic for populations that can't afford it. So briefly on the kind of heart rhythms that we're seeing with these devices in healthy populations. So here at Stanford, we collaborated with Apple to do the Apple Heart Study to look to see whether or not a smartwatch-based irregular pulse notification algorithm could identify atrial fibrillation. But as a sub-study of this, we looked at what were the arrhythmias that these PPG-based algorithms were flagging other than atrial fibrillation. And so we looked at this in three different ways. One is just looking at the heart monitor patches that they wore. And for every patient that wore a patch that did not have atrial fibrillation, about 300, we looked at what the rhythms were. Then we also said, okay, for the patients that at the time that the watches said there is irregularity happening, what were we seeing on the patches? And then this algorithm was designed to require multiple irregular PPG detections before it would flag a potential AFib event. And so we looked at these as well. And so on the right, I have the results from the analysis too, where we just looked at the irregular, PPG measurements coupled with what we were seeing on the heart monitor patch. And there's lots of premature atrial contractions during these, a few premature ventricular contractions. These patients are largely not having sinus rhythm during these detections. So it is working, it is detecting irregular rhythms. But we generally think of premature atrial contractions in most scenarios to be relatively benign, and workups often don't point to pathology or to necessary for treatment. And so there certainly is some risk in these in healthy populations and cardiac rehab populations of identifying certainly irregularity and arrhythmias, but us as a community not knowing best how to handle those. Touching upon clinical integration, which is something near and dear to my heart, and I think is very, very important, is patients have these devices. Many of them are purchasing them on their own. Sometimes we as a community are recommending these devices to patients. And then there is all this data, and it is not clear exactly how to handle it. And so here at Stanford, myself, Abba, and our informatics department have worked on and launched a workflow for a fully integrated workflow with this device data. And so the data is stored in our electronic health record. It can be reviewed by physicians and documented. And there's CPT codes now for remote monitoring, allowing for billing of this work. And so we modeled this workflow on implantable cardiac devices like pacemakers and ICDs on the remote workflow that has been used, for these devices now for better part of 2 decades. And we built this so it is not, only available for specific devices, but scalable across devices and different data. And we integrated into our how our clinic appointments are scheduled and patients notified for those for routine in-person visits. And so as an example, a patient who has a remote monitoring transmission, it will be scheduled as a clinical appointment. They will get a notification telling them, hey, you need to transmit your data. It's been 30 days. And then we would receive it, review it, and then notify them the results of it. And then also for discrete data like blood pressure measurements, the data can actually flow directly into our EHR, and you can write an order saying, EHR, don't notify me unless the blood pressure is above a certain number or below a certain number, to try to reduce the notification fatigue that clinicians can experience with these data sources. And so our hope is that with this clinical integration that we can, increase the value of these devices and their applications and make them more relevant, both more broadly across, cardiovascular medicine, but also for cardiac rehab patients, should they be appropriate for them. Another area that we've tried to, promote data access and really integration of data is with telemetry. So, historically, telemetry is only viewable on a computer screen on the patient floor. And that's just, from my perspective, totally unacceptable. It's such a rich data source. And there's, for instance, in the patient that we reviewed on their telemetry, incredibly concerning arrhythmias. And if that telemetry had just been seen by, someone with experience reviewing telemetry, then they likely would have been sent directly to a hospital instead of home. And so here at Stanford, we have built out using a third-party application called Airstrip One, mobile access to telemetry and waveforms, including telemetry, arterial blood pressure, and pulmonary blood pressure monitorings and pulse ox. And this is all available in real time. So this is a video of me showing what this looks like, but I can right now pick up my phone and look at the telemetry of any patient in Stanford Hospital. I can look at all of the alarms they've had. I can turn back to any point in time and see what the heart rhythm was. And so, it'll be really exciting to see how, technology like this starts to get scaled outside of, these siloed healthcare systems. And, you could imagine a future in which, we have access to telemetry outside of our main hospital, perhaps at an affiliated cardiac rehab facility. And maybe there's a concerning arrhythmia and they are able to request a same-day e-consult, and they message us and we pull up our phone and we quickly look at the arrhythmia and we say, nothing to worry about, looks great, continue rehabbing. Or we look at it and say, that's complete heart block, you got to send them to the hospital now. And the last, kind of data availability clinical integration I'll touch upon is ECGs. And so this is kind of similar to the telemetry. this has bothered me for many years, that when we perform ECGs on our patients, and we do about 100,000 of them per year here at Stanford Healthcare, they're not available remotely on our phones. And so this results in, unfortunately, a lot of non-HIPAA compliant sharing of ECG images, where people take pictures and send the images, but that's, really not a great idea for a variety of reasons. And then, specifically for patient care, there's delays in getting those images. If you're receiving them in that format, they can be blurred images or at poor angles, you can't really determine the arrhythmia. Then we actually did an analysis where we said, if a patient presents with a major heart attack, and assuming a slight delay in proper identification of that heart attack due to these images not being available remotely and instantaneously, if we did provide this functionality where you could on your phone pull up an ECG instantaneously as soon as it was obtained in the hospital and look at it, how many major heart attack patients would need their ECG reviewed like this to prevent a death? And the analysis said it would take only 83 patients. And so we launched this about 2 months ago. And I'm using it every day, which is probably the highest use of any person in the hospital. But I think this also has a lot of applications where, when these kind of workflows and technologies break out of our silo here at Stanford Healthcare into other institutions, if people are having concerning arrhythmias, you do an ECG. Perhaps we have a workflow for a same-day e-consult. We look at the ECG instantaneously, and we have an answer. So in conclusion, cardiac rehab patients are obviously at risk for arrhythmias, both in our case presentation, and I'm sure you all are aware. There's a lot of digital heart rhythm devices, now available across various form factors, price ranges, device operating systems, ecosystems. And clinical integration remains, I think, a real critical point. And we're trying very hard here at Stanford to address that pain point. And it's going to be exciting to see, how can we utilize these devices to improve patient outcomes, being really conscientious not to add noise to patient care, which I think certainly we're all concerned. There's a risk of doing these devices where, if everyone's checking all these heart rhythm, measurements, heart rate measurements constantly, and there isn't any evidence that that's going to provide them benefit, there's always a cost in doing that as focus is turned away from things that may be more important. Very briefly, I know this has been, I think, emailed out and kind of shown as a bumper in between presentations. Here at Stanford, in a similar vein of trying to kind of break barriers and make access more ready, we have this Stanford Cardiovascular Health Referral app called Flare. And so this is a way that, referring physicians outside of Stanford can reach us to engage with us and refer patients. So certainly look into using that, or we enjoy using it very much. Thanks, everybody. Was Eleanor faster? I think she might have beat me.
I don't know. You guys are probably tied. Thank you, Dr. Perino. What an excellent overview. I think you can tell by the claps and the thumbs up how well received, even though your talk being last of the day, its pertinence is clearly important. But we have had a packed day of learning, and we've seen the scientific evidence for and seen a glimpse of the future for cardiac rehab in a variety of situations and patient populations. We have learned about the tremendous amount of work that's been done and the work that we still have to do. We are thankful for the collaboration and the work that is being done by the AACVPR, ACC Northern California, HAACC, and the Million Hearts Initiative. I want to kind of close our session today with a couple of housekeeping items and some thank yous. So Dr. Perino, there are some questions in the chat regarding your suggestions for monitoring devices. And so I will let you address those. For the housekeeping items, for the CME credits, you will be getting an email with a post-event survey. Please fill that out. And if you have any questions, please feel free to email us. I will share my screen. With some email contacts. But in terms of thank yous, I really want to thank all of our exceptional speakers for taking the time to share their knowledge with us today. We were also very fortunate to receive educational grants from Abbott Labs, as well as Moving Analytics, who sponsored our event today. So we are very, very thankful for their generous support. I would also like to thank Stanford CME, Stanford marketing team of Jesse Perez and Sarah Fan for getting the word out and helping put today together. Of course, I want to thank Stanford IT for helping us get through without too many glitches. And I know you've seen a lot of me today, but really there was a team of us. I don't know if you can see, can you all see my screen, hopefully? Alex, is my screen visible?
Yes,
It
we're
is.
able to see.
Okay. But there was a team of us working together to make today happen. So I really want to sincerely thank my course co-directors, Dr. Levin, Dr. Marin, and of course, enough cannot be said about Jonathan David. So we are very thankful, most importantly for you, for taking your time on a Saturday to sit through 8 hours of this webinar and learn the importance of cardiac rehab and what we need to do to support its transformation. And the way I will leave you with is transformation is not a single action, but a process. And we as a community of multidisciplinary professionals working in the cardiac rehab space took an important step today. By empowering ourselves with information and working together, we can be stronger and more successful in improving outcomes, access, and experience of our patients. Because after all, improving the health of our community is why we are all here. I will leave you with a call to action. Please consider what you've learned today and one thing you will do differently to further transform your practice in cardiac rehab. And again, you have our email contacts, our Twitter handles. If there's something that we can do to help support you, please let us know. And I will ask Mario to go ahead and end the Zoom at this point. And thank you again